everyone to this cardio colloquium here today. And we are really grateful for all of you for joining this evening, sparing some time from your busy schedule. So, without any further delay, I would just like to take you through what we are going to discuss here today. So, we are going to talk about RAS blockers in acute MI from Save to Paradise MI. Do we have a verdict? And to discuss on this interesting topic, we have expert panel and our moderator, Dr. Anupam Goel. So, ma'am is a DM cardiology. She doesn't definitely need any introduction. She's the director of interventional cardiology at Max Hospital, New Delhi. We also have Dr. Samir Kubba, who's again an eminent faculty. He's the director and unit chief of cardiology at Dharamshala Narayan Super Specialty Hospital, New Delhi. Dr. Asim, again, a very esteemed personnel in the field of cardiology. Sir is a director and head of cardiology at the Indian Spinal Injuries Center, New Delhi. And finally, we have Dr. Amalpal Singh Gulati as well. Sir is the senior consultant and head department of cardiology Synergy Institute of Medical Sciences at Dehradun. So we are really grateful to have all of you here today and looking forward to a very meaningful and insightful discussion with all of you. So over to you, ma'am. You can try sharing your screen and we can begin RAS blockers in acute MI from Save to Paradise MI.
Sure. I think as soon as you stop sharing, it will allow me.
Yes, ma'am. Yeah.
Mm. Can you see my slide?
Yes, ma'am. We can see your screen.
Right. So we'll just go to the next slide. Okay. Hi, good evening, friends. We have a very interesting topic actually. RAS blockers in acute MI. We have a whole lot of literature from past 25 years from Save to Paradise MI. But still, do we have the verdict? It's a discussion of topic with my esteemed panelist colleagues today. Let's see what all we discuss and how we can make it useful to have a verdict, if possible, for the fellow cardiologist. Post MI, we have several molecules which we can use, especially when there is LV dysfunction, in the form of ACE inhibitor, ARBs, ARNI, and we finally will discuss what do the current guidelines suggest to reach to the conclusion. Let's first have a look at the evidence of ACE inhibitors in the field of MI. We have a study ranging from SAVE, ARI, and TRACE. SAVE was a good study from around 25 years back, which used captopril, then ARI with ramipril, and TRACE with trendelopril. Let's have a look at these one by one. SAVE was published in 1992, Survival and Left Ventricular Enlargement Study. It was a randomized double-blind placebo-controlled multicentral trial which included patients with myocardial infarction who had LVEF less than 40%. It was not required that patient have overt features of congestive heart failure. They were randomized to the drug between 3 and 16 days, and captopril was used in a maximum dose of 50 mg 3 times daily versus placebo. Patients were followed up from 2 to 5 years, and the results showed that the ACE inhibitor group captopril showed 19% reduction in mortality and 25% reduction in recurrent MI. The cavity dilatation was reduced, and these benefits occurred equally in those patients, those who received lysis and beta blockers and those who didn't. So the effects were independent of the other therapy, and there was significant reduction in cardiac output. Second study is ARI, acute infarction ramipril efficacy, very interesting trial, which had randomized double-blind placebo-controlled multicenter. These patients had acute MI with transient or persistent heart failure. So they were a relatively sicker patient group who were randomized to ramipril versus placebo between 3 to 10 days, around 2,000 patients, and they were followed up for 15 months. Ramipril showed significant reduction in mortality by 27%, 19% reduction in rate of MI and stroke at 6 months. which was very impressive. This study later had a then we had an area extension study, which was when these patients were studied for 60 months, almost 5 years, 600 patients who participated, and the beneficial effects of Ramipril started early after MI and they were sustained over 3 to 4 years. Despite the drug was discontinued at 1 year, the beneficial effects were there to stay even after 5 years, with relative risk in a reduction in mortality of 36% and absolute risk reduction of 11%. TRACE is another study which used trendopril in the same subject group. And it also had beneficial effects, showed 25% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. Minded ACE inhibitors have been shown to show the reduction in sudden cardiac death as well, like beta blockers. So there are other several trials which showed the beneficial effects of ACE inhibitors in this subgroup, ICIS-4, GC3, and CCS1, which showed that anterior wall infarction, especially with LV dysfunction, ACE inhibitors in the form of captopril, lisinopril, showed better mortality and better outcome when used against the placebo. This is what we know about ACE inhibitors for a long time, more than 25 years. Now let's have a look at ARB. What evidence do we have? Use of angiotensin receptor blockers in post-MI. The prominent trials are Optimal and Valiant, which had decent patient size. Optimal had 5,500 patients, Valiant had around 10,000 patients. And the admission criteria were MI with anterior Q or heart failure and LV, dilated LV, or in Valiant, MI with LVEF of less than 40% or evidence of heart failure. The drug used were losartan and valsartan, which we all know very clearly. Optimal was published in 2002. Optimal trial in myocardial infarction with angiotensin antagonist losartan. Losartan was compared to captopril in this trial, and there was non-significant difference in total mortality in favor of captopril. ACE inhibitor, after the trial, it was postulated that ACE inhibitor should remain first choice treatment in patients after complicated acute MI, and because of its drug, rather some patients, a subgroup showed increased mortality. So losartan cannot be generally recommended in this population was the outcome after this trial. Valiant used valsartan. There were three groups: valsartan alone, captopril alone, or captopril plus valsartan, and these groups were followed up. So mortality from any cause and cause-specific mortality were similar in all the three treatment group. So it was concluded that valsartan has similar beneficial effects as compared to captopril, and joining the two or combining the two does not have added benefit. Rather, there could be more incidence of adverse cardiac events. So I'd like to have a question from Dr. Samir Kuba. Dr. Samir, what do you prefer? What is your preferred agent in ACS? Whether patient is undergoing revascularization or not, and what do you think? What molecule is a good molecule in compared in RAS blocker group?
Yeah, thank you, ma'am, for that question. And I think it would depend upon the clinical scenario. And if we look at classical MI with LV dysfunction severe, I think still ACE inhibitors are the choice of drugs which we use, especially patients who have severe LV dysfunction, something like 30-35%, large anterior MI, ACE, ARB, naive or ARNI naive. But somebody who is already on a ACE or a ARB or ARNI, who is already taking that drug and sustains an infarction, taking that drug for hypertension or something of other sort, I mean, maybe we continue with the same. But all said and done, whenever you have a complicated MI, STEMI, non-STEMI, severe LV dysfunction, I still believe ACE inhibitor is my first drug of choice. In ACE intolerant patients, I would switch over to an ARB. And ARNI, obviously the Paradise MI will be discussing that, did not show a clear-cut benefit. But if somebody is hypertensive, has a good blood pressure, a relatively younger age, not frail, I would not hesitate even starting ARNI and see how it goes, because ultimately, whenever you have to look at the improvement in the LV function, the kind of benefit with ARNI in the improvement of LV function, we have not seen with any other drug. But having said that, to make things simple, severe LV dysfunction, acute MI, first presentation, heart failure, borderline hemodynamics, I think ACE inhibitors are the drugs of choice.
Right. Thank you so much, Dr. Sameer. I think most of us agree to what you said. This is how we practice. And ACE inhibitors are easy to use, especially if the patient is naive to RAS blockers in the setting of MI with ARBs. Thank you so much. I think that's a very great thing we discussed. Dr. Asim, I'd like to have a question from you. Do you switch to an ACE inhibitors in your post-MI patient if patient is already taking ARB? For hypertension, if patient is taking ARB, or you just think that it is okay and we can continue?
Yeah, thank you, Dr. Anupam. I think given an option, the ACE inhibitors would be the first choice in MI patient. But having said that, we also have to find out why were ARBs given in the first instance in this patient. Suppose this patient was having cough with ACE inhibitors, and then you had started with ARBs. Again, starting ACE inhibitors might not be, he might again start having cough and all those things, side effects of ACE inhibitors. So we might have to again switch over to the ARBs. But given an option, if we don't know whether why this patient was taking ARB for hypertension in the first instance, I would prefer starting him on ACE inhibitor in the post-MI phase.
It's very balanced. That's right. Because instinctively we know that post MI we have stronger data with ACE inhibitors. But if somebody is already taking ARB because of any possible side effect or ACE were not tolerated, then why not continue with that? Otherwise, we all feel that ACE inhibitors have shown stronger beneficial effect in this subset of the patient. Right. That's good. So I think we will proceed further for further discussion. So now let's discuss ARNI. ARNI in the setting of post-MI patient. We have a very interesting trial, Paradise MI, which we all have discussed multiple times. We all have our own inferences from it. It was the first trial for ARNI in post-MI setting. A good data, good trial, well managed. The patients who had acute MI from day 1 to first week, who had LVEF of less than 40%, with or without signs of pulmonary congestion, plus any risk enhancers in the form of advanced age, more than 70 years, atrial fibrillation, with EGFR less than 60, LVEF of less than 30%, patient in CLIP class 3 or more, diabetic, or already post-MI, or STEMI which was not reperfused. These were the patients who were included in the trial, and they were distributed between sacubitril valsartan. The target dose was 200 mg twice a day, 2,800 patients, and ramipril with a target dose of 5 mg twice a day, similar 2,831 patients. Paradise MI was an event-driven trial, and the primary endpoints were 711 events. Median follow-up was around 2 years. The primary endpoint, as we all know, are cardiovascular death, heart failure, hospitalization. And India contributed highest number of patients in the Asia Pacific group, 333 patients. So we can definitely relate the findings to our own population in the trial. There were mixed STEMI and NSTEMI patients. It was a well-controlled trial. The distribution of complications, STEMI and STEMI location were matched extensively between ARNI and ramipril group. So the results showed that the risk of cardiovascular death, first heart failure, hospitalization, or outpatient heart failure was less in sacubitril valsartan group with no statistical significance. The results were comparable. Ramipril and valsartan has almost the same outcome when we talk about the primary outcome of the trial. The death was also, there was no significant difference between the deaths between ramipril and sacubitril valsartan group. And it was concluded that sacubitril valsartan did not result in a significantly lower rate of cardiovascular death, heart failure hospitalization, or outpatient heart failure requiring treatment. There was pre-specified observation of reduction in both the investigator reports, which support incremental clinical benefits of ARNI, but the safety and tolerability of ARNI was found to be comparable to that of ACE inhibitor. Very interesting trial. It was analyzed differently by all the cardiologist group. There were many editorials, many news about that. Medscape concluded that Paradise MI can't be showed that ARNI cannot beat Ramipril in patients with acute MI. TCT-MD showed that ARNI does not surpass ACE inhibitor after acute MI, and Medscape shows that Paradise MI makes me question the benefits of ARNI because ARNI failed to show the superiority over Ramipril. The data from American College of Cardiology summarized that ARNI did not outperform ACE inhibitors after MI, and it missed the significant heart failure event reduction mark in Paradise MI. This was the feeling from most of the stalwarts in cardiology. Do we have Dr. Gulati with us? Otherwise, we can discuss it among ourselves, three of us. So what do we think? Has the Paradise MI result changed our clinical practice when we talk about post-MI patients? Can I have your inputs on it, Dr. Asim? Or is there anything else you'd like to?
Yeah, I actually failed to understand why this trial did not achieve the primary endpoint. What are your inputs about it? Because this has been very surprising that till now we have seen that ARNI. There's been so much. This has come as a magic drop, and suddenly we find that Paradise MI results are just the contrary. So what has happened that suddenly it is very difficult to change the practice because we have been using ACE inhibitors for a long period of time, and then we started using ARNI, and it has been quite some time that we have been using ARNI. So what has happened that the results have not come to equivalence, or the p-value has not been significant in achieving the endpoints in this trial? What are
Right.
your about it?
What do you think, Dr. Sameer? Let's just take his opinion as well. Then three of us will discuss.
Sure.
See, I think nowadays what happens is everything comes as a breaking news, and we fail to read in between the lines. So, I mean, obviously, ARNI is going on everywhere, and this trial suddenly had. If you look at the primary endpoint, maybe the p-value was not significant, but if you read between the lines, the patients numerically, the lesser number of events were noted in the ARNI arm when compared to the ACE inhibitor arm. And if you look at recurrent cardiovascular events, they were again lower in the ARNI arm when compared to the ACE inhibitor arm. First heart failure event definitely was not significantly different, but if you look at all heart failure in patients followed up for a longer period of time, then ARNI was statistically superior for heart failure prevention, not the first event, but events after that. So, as Dr. Asim mentioned that why did this trial fail? So it might have missed the primary endpoint, but I still believe that those patients who are hemodynamically stable, do not have borderline hemodynamics, can tolerate ARNI, maybe you can start them on ARNI, but many times patients are sick, they are borderline hemodynamics, they do not tolerate the ARNI, and sometimes an over-aggressive use of ARNI can actually lead to more events like renal failure, hyperkalemia, and patients getting dehydrated and coming to you. We have burnt our fingers. Sometimes, like in heart failure, if you look at all the guidelines say start all the 4 pillars of therapy as fast as possible, simultaneously, sequential, all those things. That's fine. But I think sometimes we go amok and run overboard because every patient is different. So the concept must be choose your patient, the right subset of patient. I feel still in the right selected group of patients, maybe ARNI is okay. If not initially, maybe after a few days, because eventually we see maybe after 2 months, 3 months, 4 months, we generally try to shift all these patients to ARNI from ACE inhibitor because they become so-called stable heart failure. Maybe in acute decompensated heart failure, the hemodynamics are such that these patients do not tolerate the ARNI. Or maybe neprilysin inhibition has some other effect. Maybe the bradykinin has some other effect. I don't have an answer to it. But still, in my practice, I still use ACE inhibitors post-amine, especially the sicker group of patients, and then over the period of time, switch them to ARNI. These
I
are
think
some of my thoughts. I could have made things more complicated rather than
no,
easy,
no, no.
but I
This
think
is what discussions are for, and both your views are right, you know. But Dr. Kumar, there are a few things which we need to understand. You are very right that the numerically the adverse event rates were less, which we expected. They didn't reach the statistical significance value. But there are a few things which really need to be sorted further. As Dr. Asim said, you know, the target dose of ARNI was 200 mg twice a day. How many patients are we able to reach this dose post MI? We are not. So maybe the beneficial effects, whatever were seen, would be less if we are not able to reach that dose. When we start ARNI post MI, the hardly we start 50 mg half tablet twice a day. I mean, as compared to Remipril, which is easy to be started at 1.25 mg once a day, twice a day, then 2.5. It's easier to reach a target dose of 5 mg twice a day for ARNI, Remipril, which was used in the trial. But the target dose of 200 mg twice a day, I think it will take some time for us, especially post-MI subgroup, unless and until, of course, patient has good hemodynamics, is stable, and high blood pressure. So, of course, this trial really generates lots of discussion. We are very right. That's why three of us are talking different, because it can be looked at from so many different ways. You are right. If we are in a hurry to increase the dose, of course, patient can have hypotension, AKI, especially post revascularization, already compromised hemodynamics, hyperkalemia. Then we have to hold back on MRAs or something like that. So it is a field which is still evolving. We have ACE inhibitors which have shown to be beneficial. How much or how much over that ARNI can do things, I think we'll come to know in a few years. Or we have to go slow, start with ACE inhibitor in this subgroup, then go slowly. Yes, this is what we are all discussing. And there's so many ways. It has huge data. This was a well conducted trial. The numerical numbers were definitely, complications were less in ARNI. But when we look at it from practical solution, I don't think we are going to use 200 mg twice a day dose very often. So it definitely is a mixed bag. We can, and you very rightly said, every patient is different. We can't be just guided by what guideline is saying. They are to guide us. Every patient is different. Borderline hemodynamics, you and me would definitely start with Remipril, small dose. But yes, if patient has been taken ARNI and is well tolerating, then why not? That's true.
yeah, and even in heart failure, I don't know, maybe we reach a 200 milligram BD dose of ARNI maybe in 10-15% of patients. Most of the patients are either on 100 BD, maximum 150 BD, or even 50 BD. And we see sicker patients of heart failure in our practice, Indian patients, severe LV dysfunction, borderline hemodynamics, BP remains 1995. So to achieve a 200 milligram BD dose is a problem. And that is why identifying your patients from the beginning is very important. And in acute MI situation, it is different from the stable heart failure. I mean, we should not use the word stable heart failure, but acute MI situation has more
We
of
know what we
hemodynamics.
are talking. You're right. And especially in this subgroup, I mean, ACE inhibitors are better maybe through their bradykinin pathway as well.
Yes,
It causes
absolutely.
vasodilatation. It causes endothelial stabilization. So
Yes,
those beneficial effects would also come into play when we talk about ACE inhibitors post-MI. Maybe that is
completely,
the reason
completely.
Remipril is the only molecule which has been able to show the benefits, right? Good. So that's what.
Absolutely, Dr. Anupam. But see, the events have definitely been less with the army as compared to ACE inhibitors, although they have not reached statistical
Significance.
significance.
Hmm.
So we cannot disregard this fact that ACE inhibitors are equivalent to ARNI in this subset of patients. What I feel is that, as Dr. Kuba also said, that probably this trial started seeing the first heart failure event, and probably the burden or repeat hospitalizations for heart failure might not have been assessed for a long period of time, because the trial was stopped once that patient came into the first event of heart failure. And had that patient been further followed up for a period of few years more, probably then that patient, we would have known whether the continuation of ARNI as compared to the ACE inhibitor would have benefited that population or not. But of course, the present data of Paradise MI is quite, I would say, intriguing, and
It is. It's
yeah,
right.
till that time, of course, we
Makes
might
us ponder what's happening.
get back to
I think the
is
bottom line is don't take any trial as a breaking news. Read in between the
absolutely,
lines and decide which patient of yours can
yeah, and it
actually.
has to be
If
individualized
my
therapy as
patient
per the
is
patient.
an LV dysfunction of 40-45% with a BP of 150-100, primary angioplasty done, LAD done, and
Anything can be given to him.
yeah, so I mean, I, difficult actually, but I think probably severe LV dysfunction, borderline hemodynamics, still ACE inhibitors definitely would. We actually at one point of time used to use captopril because it is a short-acting ACE inhibitors, patients with very borderline hemodynamics. And during our training days, our seniors used to give captopril low dose, see the blood pressure after 6 hours. Somebody who has a BP of 80-90. I mean, that is one thing which we don't use now because we are more confident and revascularization has become better. But again, we at times get these kind of patients who are very, very sick. I have a patient today in my CCU. We are not able to take her off the inotropic medication. Her borderline blood pressure is borderline. So today we achieved a BP of around 90-95. And I was thinking if I have to start an AC inhibitor for her because LV is around 20-25, why not captopril? Because she is not tolerating anything else. So I mean, these are certain things which we can always discuss, even with the historical molecules.
Right.
Absolutely. Is Dr. Amarpal, has he joined or not?
I think we'll move ahead.
Uh,
I
okay.
mean, we have discussed now.
Sure.
So when he comes, we can, of course, take his inputs on this and then move again.
Yeah.
So, what do the current guidelines suggest? Let's discuss that because that's what we all going to practice, and this is what we all need to understand. So, as per the guidelines from ESC 2017, ACE inhibitors are the drug of choice for STEMI with anterior location with LVEF of less than 40%, who have early heart failure, have diabetes or hypertension. ARBs can be used if patient is not able to tolerate the ACE inhibitors, but use of ACE inhibitors for all STEMI patients is still class 2A. Have a look at the 2023 ESC guidelines for management of ACS. So ACE inhibitors are a class 1A. They are recommended for those patients who have heart failure symptoms, LVEF of less than 40%, diabetes, hypertension, or impaired kidney profile. But routine ACE inhibitors are still class 2A. I mean, they are more established when there is reduction in LVEF or patient has heart failure features, and not as a general drug when the heart failure, when the LVEF is preserved. 2020 AC guidelines also look at ACE inhibitors or ARB. ACE inhibitors preferable in patients with heart failure with reduced EF, ARB in case patient is not able to tolerate ACE inhibitors because of cough or any other thing, and then the ARBs can be used. This is a very interesting state of art review which discusses the time dependent therapies for post MI heart failure patients. So now we know a patient who comes with STEMI, has LV dysfunction, comes with index MI. We want no patient needs to have a revascularization at the earliest, especially for a patient of cardiogenic shock. So immediate reperfusion is recommended for ST segment elevation patients. And what we should try is early introduction of ACE inhibitors, because now we know that ACE inhibitors have maximum benefit when they are started on day one with LV dysfunction and acute MI. Of course, when patient has borderline hemodynamics failure for first 24 hours, we all avoid beta blockers for ongoing heart failure till the time patient stabilizes a bit. Early introduction of aldosterone antagonist for its antifibrotic effect is beneficial. It is time dependent and should be started within first week if possible. and beta blockers at the earliest opportunity when patient is able to tolerate it. And it is critical to titrate doses of medication, ACE inhibitors, beta blockers to optimal level whenever possible in peri-discharge or post-discharge time. So the recommendation is early ACE inhibitor initiation and up titration to maximum recommended dose as soon as possible to have maximum benefit of the drug. We had very interesting review by Jack. It revisited ARI and published it again, which shows that ACE inhibitors, when used in first year of this subset of patients with an EF of less than 40%, the beneficial effects were persistent even at 5 years or later. So this is a good drug which is safest and most effective to be used in post-MI infarction heart failure trial. So Dr. Samir, we have another question to discuss. Right. In the post-MI patient, post-revascularization, now this is the contemporary practice which we have. At what systolic blood pressure are you comfortable starting ACE inhibitors, and what dose you start it with? And how do you titrate the dose?
I think, madam, anything above a systolic of 90, and if the patient is off inotropes for last 24 hours, I mean, it's important to start an ACE inhibitor or ARB or whatever you feel if the patient is intolerant to. Go low and go slow, especially in the vulnerable group of patients who are elderly, frail, ladies. If somebody is having a good blood pressure, obviously you can start at a higher dose. My ACE inhibitors of choice usually are ramipril, and also I use perindopril. But I think in borderline hemodynamics, ramipril scores over perindopril because of its shorter half-life, and you can actually be more sure it doesn't cause a long-standing hypotension. Sometimes perindopril can cause that because of its long effect. But we can start with a 2 milligram low dose, which is also available for perindopril. So basically, low and slow for borderline hemodynamics and vulnerable patients, a higher dose for patients who can tolerate it, and a systolic blood pressure of more than 90 if the patient has been off inotropes for last 24 hours.
I think we agree. Dr. Asim, anything else you feel? Or I think this is the practice which most of us follow, right?
Yeah, I'm not comfortable starting at 90, although I
Theoretically, we should.
always tend
I
to
agree.
start once the
And
blood
maybe
pressure
we
picks
want
beyond
that
100. Yeah. So, I mean, of course,
200 is a
you as
reasonable.
early as possible, as Dr. Kuba said, and you have to start. But whichever dose you are comfortable with starting, the blood pressure, as far as the blood pressure is concerned, you should try to start as early as possible and build the doses depending upon the blood.
Right. So, Dr. Dhal, I have a question for you as well. In the post-MI patient after revascularization, when do you plan to start a beta blocker, and what is your preferred beta blocker? How do you titrate? And is there a role of combination of ACE inhibitors and beta blockers in this subgroup?
So, beta blockers, in my opinion, should be started early. Although in the post-revascularization phase, because all the studies whichever have been done with beta blockers have been done in the pre-revascularization or pre-angioplasty era. But with the advent of angioplasties, the things have changed. We rarely need to start additional doses of it, but still, beta blockers are very important drugs because they reduce the infarct size. And I start beta blockers early if a patient has tachycardia, if a patient's blood pressure allows, and if he has residual ischemia, then these drugs become all the more important to start early. And various trials have shown that starting beta blockers early would limit the infarct size, would decrease the it is anti-arrhythmic also, because these patients, acute MI patients, even though they are pretty well vascularized, they still have tendency to have arrhythmias. Probably the other arteries which are 90 or 95% blocked, they might cause ischemia. So for that also beta blockers would be advantageous. So they should be started early. Now, if there are no contraindications for beta blockers, then they should be started early. If a patient is having acute heart failure and post angioplasty, you feel that he has suddenly gone into LVF, then of course this is not the time to start beta blocker. He has to be first stabilized. If a patient has a drop in blood pressure, if a patient has a borderline hemodynamics, And then you should not be starting beta blockers early. So a stable patient, you should start beta blockers early. And in acute MI setting, my preferable drug, as far as I am concerned, I start with metoprolol. And a minimum dose of metoprolol, 12.5 milligram twice daily, which is to be built up subsequently. And once the patient stabilizes on these doses, then you can subsequently, you can increase the doses or depending upon the situation to get a target heart rate of around 60 per minute. And blood pressure, of course, needs to be kept beyond 100. And what is the third question? What dose do you
Combination.
appreciate? Yeah,
Combination of
I'm
ACE
not comfortable as with ACE inhibitors. I'm not comfortable starting beta blockers at a pressure of less than 100. So 100 is the hallmark when if a patient is having tachycardia, I start with a low dose, maybe 12.5. If he's not able to tolerate 12.5, even 6.25 is good enough for him. Because starting with 6.25 milligram of metoprolol also results in decrease in the heart rate and subsequently decrease in the oxygen demand and subsequently decrease in the infarct size in these patients. And
very
of
right.
the blood pressure allows a combination of ACE inhibitors and beta blockers is welcome. And ACE inhibitors definitely have to be started prior to beta blockers, and subsequently beta blockers can be added and built up. Both the drugs need to be built up subsequently.
Right. I think choice of beta blocker could be very individualistic, carvedilol, metoprolol, or if patient is stable, bisoprolol. That's right. But very right. I think I agree. This is the how we go. As soon as patient is out of acute heart failure, lungs are not wet, we like to introduce beta blockers, ACE inhibitors before that, if possible. Yes, of course. And both of these drugs are important in this subgroup of the patient. If the hemodynamics allow, then we like to use both of them. Slow, steadily, as Dr. Kuba is telling, which is very important. We can't just suddenly undo whatever is being done. Even after revascularization, you and me want to have a basic blood pressure for the patient for the vessel to flow. We don't want
Absolutely.
patient to have hypotension and then have stent thrombosis or something else. So we have to balance everything. So small dose of ACE inhibitors, beta blockers, and then building it up seems the right approach. Anything, Dr. Samir, you want to add? Or
Yeah, I agree with it. Just 2 points, just to reiterate, almost it's just like similar points. Number one is just like you use an ACE inhibitor and not an ARNI for borderline hemodynamics. Similarly, I would use probably metoprolol, as Dr. Dhal mentioned, for borderline hemodynamics. Maybe bisoprolol if the blood pressure is slightly on the higher side.
okay.
Yeah, or carvedilol or bisoprolol, whatever, because carvedilol has an additional alpha effect. But I use more of bisoprolol and metoprolol rather than carvedilol, and that choice can be individualistic. Second is sometimes the patients may be having tachycardia as a compensatory mechanism of severe LV dysfunction. So we must be very cautious of that situation that you add a beta blocker and the patient goes into failure. So that's a very tender phase. So clinically, with your investigations, with your biomarkers, I mean, when to initiate beta blocker actually at times in patients who are relatively sick, who have just come out of cardiogenic shock, who are off IABP or inotropes, maybe not being very aggressive. You may wait for 1 or 2 days and then start it, because that tachycardia may be a compensatory mechanism. And sometimes your severe LV dysfunction patients may have tachycardia because of volume under depletion. And we always feel that the patient will be overloaded. But we have seen patients who are LV of 20-25%, maybe they are volume underloaded. So seeing the IVC, looking at the CVP or the pulmonary capillary wedge pressure, all these things become important.
Veins, right? Like Dr. Dhal said, that patient has to be out of acute congestive heart failure phase when we start beta blocker. True. So let's move ahead. So let's just discuss, is all the ACE inhibitors same, or there is anything particular about ramipril? It's an interesting data where the elderly patients who have been taking different type of ACE inhibitors were studied. 7,500 acute MI patients, 30 days post discharge till 1 year, who were on various ACE inhibitors, enalapril, lisinopril, fosinopril, ramipril, captopril, and perindopril, and along with the standard treatment therapy. And let's see the reduction of mortality with different ACE inhibitors. So what this analysis showed is ramipril had those patients who were on Remipril had maximum survival at 1 year as compared to other ACE inhibitors. Perindopril is close second. And similarly, here cumulative survival was maximum with Remipril as compared to other drugs. So it was seen that not all drugs within the class of ACE inhibitors are the same, and patients who fill prescriptions for Remipril had statistically significant lower mortality within the first year after acute MI than did use of several other ACE inhibitors. Now that's a little, every drug is different. It's not the class effect which was shown by this analysis. So, Dr. Sameer, I'd like to ask from you, post revascularization, if you find LV dysfunction, but patient is not overtly in congestive heart failure, so what would you like to start? And what really directs your therapy? I think most of this is discussed earlier.
Yeah, absolutely.
Let's just give it in a line. Um,
I think we have already discussed it, and with
that's
even
true.
in asymptomatic without clinical heart failure, LV of less than 40, we would like to use a RAS blocker. Choice of ACE inhibitor, ARNI, I think we have discussed it enough.
Right. So let's move. We have one question for everyone. 55-year-old smoker and diabetic hypertensive patient with dyslipidemia, LDL cholesterol high, with no heart failure, no LV systolic dysfunction. So for primary prevention, it's a little out of context question. But what are we looking at? ACE inhibitors for as antihypertensive or ARB for such patient? Any preferences, or we are okay with ACE, if not tolerated, ARB?
I think, Dr. Anupam, we can have this discussion. We will have a problem with
We'll
it.
keep on having, because this is such a wild area and this is primary prevention. That's right. So let's just.
But
Now,
I think there are one or two points which I would like to mention here. Number one, if you go back to this slide, yeah, absolutely. So numerically, both Hope and Europa were positive. But there was some controversy regarding on-target versus transcend. So on-target showed the benefit of telmisartan, but transcend actually refuted that. So if you look at numbers, probably 2 for that and 1 for the ARB. So, but anyways, I think not much of a difference. We are discussing about ARB MI paradox, and we have people for and against that. But to me, it appears it hardly makes much of a difference except the tolerability. And somehow or the other, with over marketing of the ARBs, somehow the ACE inhibitors have gone back. And as you initially mentioned in your discussion, that bradykinin is a good molecule which has been made the villain because of cough, but actually it improves the endothelial function. So I think we have to weigh the risk benefit. Tolerability probably with ARBs is better, and that I think drives our clinical practice. We don't want patient to come back and complain of cough. Sometimes we are busy in our practice, we start an ARB, but I think hard clinical endpoints, still I think ACE inhibitors are better than ARBs, especially in the post-MI-LV dysfunction scenario. Now, this scenario which we are discussing is a stable CAD, not many risk
CAD
factors.
even,
Yeah. Yeah, so I mean, Hope and Europa both showed a benefit. On target showed a benefit for telmisartan, but transcend was the actual, I would say, question mark or controversial area. So hardly, I think the bottom line should be use whatever you are comfortable with.
Dr. Samir, you're very right. Actually, with the flooding of ARBs, we are sort of forget the Remipril.
Yes.
And cough also wasn't that bad. I mean, it was there, but not that bad. But since we started having an ARB and we presume that the mechanism of action is almost the same, the beneficial effects are almost the same. So we just put ARBs in the shoes of ACE inhibitors and thought that we are doing the right thing. And it's good that we have some discussion so that we can go back thinking, is it really the same? Is it really beneficial, or we need to do something else? So a word about cough in these patients. So how much common is the cough when we use ACE inhibitor? In Paradise MI, it was 13%, but only two contributed to discontinuation of the drug in 2.3% versus incidence of 9.1 in army and discontinuation of drug in 1.2%, which is not huge actually. And we know that ACE inhibitors cause cough, but I mean, most of this cough is not too bad. At times, you discontinue the drug, reintroduce, it gets better. And bradykinin, as you very rightly said, I wanted to discuss that. It's a good molecule, it's a good thing. It is responsible so many beneficial effects of ACE inhibitors which ARBs lack. Then ARBs are not able to cross the blood-brain barrier. There are so many things which are unique to ACE inhibitors because of their other action as well, which is other than just blocking the angiotensin receptors. So the ramipril needs a relook at that. So I mean, are we really deterred by cough? That's also a very valid question. But yes, if patient is truly intolerant, then we have to change. Other than that, I think we can have a relook at ramipril as well. So we can come to the take-home message now, right? For post-MI patients with LV dysfunctions, ACE inhibitors have consistently shown reduction in cardiovascular death and all-cause mortality. Large number of literature base. In this scenario, ACE seems to have class effect. However, ramipril is a preferred ACE inhibitor, especially in elderly. Paradise MI, which was the first and only clinical trial for ARNI versus ACE inhibitor, could not outperform ramipril in acute MI population, which is true. Then ramipril 10 mg is the dose which offers the maximum benefit. So it is best to use it in the right medicine dose. If we want to have the good effect, then the dose has to be right. Thank you so much. I think if there is any more discussion, we are happy with that. I'll stop sharing the screen, and Dr. Ronak, you can take it from here.
Thank you so much, ma'am, and thank you so much, everyone, for a wonderful discussion. It was really quite insightful to see how you interpret the trials in the most, minute manner. It's good to see how Dr. Samir also mentioned that you need to read between the lines and somehow also try to, go deeper and deeper into the data that is presented to us. So, Surendra, are there any other questions from the audience that we can take up?
Yeah, just a moment. I will just check. Yeah.
It was also quite good to know regarding this dose of ARNI which Anupam ma'am spoke about, especially in the Paradise MI trial, and how many of these percent of patients do receive the same in the clinical practice. So until Surendra checks that, maybe I could ask all three of our experts, what percentage of your patients would you suggest are currently receiving 200 mg of ARNI?
As Dr. Samir was trying to say, stable heart failure, though we all know this is no term. But yes, those heart failure patients who are relatively stable have reached this value, or patients of hypertensive heart failure who can tolerate higher doses of ARNI. Other than that, I think most of the patients, especially post-MI, we will not like to have this dose. And they're unlikely to reach this dose anytime soon after MI. And I think two drugs are very good. The field is open. I don't think we have a clear verdict yet. We need to read between the line. We need to read more and more, have more such forums to discuss, so that we are open to ideas. Once we are bombarded with everything new molecule coming, maybe we just start thinking in one line. Unless and until we take a pause, go through the literature again, discuss it amongst our peers, and then I think we are better informed to take a good decision for our patients.
Right, ma'am.
Yeah. So I think, Ronak, we have a couple of questions. So I think, ma'am, if you allow, we can go ahead with it. Yeah. Yeah. So one of the interesting question. So Dr. Manoj has asked, my question is in selection of ARNI or ACE inhibitors in post-MI or heart failure, which is easier to handle, cough or hypotension? So I think
that's very interesting, very right. Which is easier to handle. Of course, hypotension makes us all scared. So cough is easy to handle. And then, if patient has really excessive cough, then we can even stop the molecule. We don't have to choose between the two. Try to give small dose of molecule ACE inhibitor as we discussed. And if there are the borderline hemodynamics, hypotension is not a good idea, especially in post-MI subset. So it's important to maintain a good systolic blood pressure, very right, preferably 100, definitely not less than 90, because then inotropes would undo everything good we are trying to add. So cough is a lesser devil, I believe.
Okay. So ma'am, we have another question from the audience. Maybe this will be last question since we are almost about the time. So the question is patient with hypertension and diabetes, how often they have underlying cardiac complication? Should we consider ARBs or ACE inhibitor in such cases as first drug of choice?
So diabetic, if we take as CAD equivalent, then most of these are at high risk of having ASCVD sooner or later. So along with the standard treatment, as we discussed throughout the meeting, ACE inhibitors or ARB, I don't think either has really shown a very significant difference other than the other group. Right, Dr. Sameer, Dr. Asim?
Yeah, actually, this is
Yeah,
what we were discussing in the last
yeah.
part of the presentation, Europa and Hope and
The,
Transcend and non-target. So
the
it is
primary
actually,
prevention
yeah.
of CAD.
I would like to make a couple of points here regarding the dosage of 200 milligram BD. I think in my practice, I've been able to achieve only 10 to 15% of patients that dose. Put ACS and heart failure together, and mostly it is heart failure. Second is
Less than 1% in my clinical experience.
okay.
You have been
Maybe
able
we
to
have
achieve it
different, yeah,
10%.
maybe the kind of patients we see, I mean, in clinic patients, acute patients, I mean, you go to a peripheral center. So I think it is diversity of practice rather than anything else.
So
But I think
hypertensive heart failure patients only respond well to such high doses. Others, post-MI patients have hardly been able to achieve. And secondly, if a
absolutely.
patient has been previously hypertensive on multiple drugs, which are not controlled on single drug, two drugs, he's taking multiple drugs. So the effect of LV dysfunction and the decrease in BP is not much. So that patient may be able to tolerate those high doses of RDs.
Yeah, in fact, it's an excellent drug for resistant hypertension. I have used in my patients who were just referred to me uh, hypertensive bleed, 4 drugs, 5 drugs, not achieving blood pressure control. And the moment you switch them to Arni 200 milligram BD, obviously gradually uptide, they do fantastic. And I think, in fact, if you look at history, Arni was developed actually as an antihypertensive agent, but Novartis did not market it because the space in the hypertension market was hardly any. But we have realized, and it's an excellent drug for resistant hypertension, and many of our patients have achieved good blood pressure control. That is another thing which I wanted to discuss. And the third thing is sometimes, it's very important to listen to your patient. I had a patient around 20, 25 years back, and I put a pacemaker for her, and she was having hypertension, and we gave her the routine drugs at that point of time. And then she started to have persistent cough. And so I switched from Ramipril to telmisartan, and she still continued to have persistent cough. Now she was something like a resistant hypertension on many other drugs, and she was an educated patient. And so I was not able to figure. She said कि नहीं इससे नहीं है मेरे को इस दवाई से होता है, and that medication was amlodipine. I said it cannot happen with amlodipine. I have never heard of it. She said कि you know better, you are a doctor, but I think it happens because of this. So I said, okay, you stop it, and we switched it over to another drug, and the cough disappeared. And somewhere in Google, I found that persistent lingering dry cough can be an extremely rare side effect of amlodipine. So I mean, no drug. And we were discussing about cough. Sometimes we feel ACE inhibitor is the culprit. Maybe there are other culprits, and maybe they have made more of villains. Like MRAs are made villains for hyperkalemia. Similarly, ACE inhibitors are made villain for cough. So we really need to look into that and do not. I think we should not believe our patients on the benefit of ACE inhibitors. That should be the message which we are discussing today. For some reason or the other, because of excessive marketing of other drugs, we have somehow forgotten the ACE inhibitors. So that I think is something which we must take home. That
That's
they
the
are as good.
purpose of this discussion today, I think. We really need to have a relook at a good molecule which we have almost forgotten. True.
Absolutely.
Thank you
you so
so
much.
much. Right.
Yes.
Floor is yours, Ronak. Sure.
No. So, ma'am, thank you so much for wonderful moderation. And Dr. Samir and Dr. Asim, it's always a pleasure hearing you out. And it was a very, very insightful discussion. We also gained so much out of it because every time I listen to, I've worked with Dr. Samir also previously. So every time there's something new that he comes up with, and I always learn from the discussions that we have. So thank you so much, and I'm sure everybody here in the audience as well resonate with what I am saying here today. Everybody is going back home, learning something new and some clinical pearls that will help them out as well in the clinical practice. So thank you so much, everyone, and good evening, and see you in the next one.
Thank you so much for giving us this
Thank you.
platform. We all learn every time we discuss with our friends, our colleagues, our peer group. Thank you so much. That's right. Thank
Thank
you.
you,
Thank you,
ma'am, for
Dr.
your
Anupam.
excellent
Thank you,
Thank
Dr.
you
moderation
very
Samir.
much,
and
ma'am.
keeping
Thank you,
everything
Dr.
on
Sami,
time.
Dr. Arsim.
Thank you,
Thank you.
Dr. Asim. Thank you. It was nice seeing you,
Thank
although
you.
virtually.
Thanks.
Too many years. Yeah.
Thank you. Bye.
Okay. Bye.
Thank you.
Okay. So, Ankit, we can stop the live. Yeah.